Okay, I have now cleansed my wound. What I'm gonna do is go ahead and doff, hand sanitize, and Dawn. Once I do that, I can go ahead and pick up my cotton tip applicator and my ruler from my clean field. So the first thing that we're gonna do is go ahead and measure the length of this wound. To do this wound is already currently in good anatomical direction. So we have 12 o'clock and we have 6 o'clock. I'm gonna take the measurement from 12 to 6 o'clock on the wound. So I'm gonna go ahead and find the edge of the wound at that 6 o'clock position, run it directly vertical to the 12 o'clock position, and that will give me 4.5 centimeters. So now in order to take the width, I'm looking for the widest part of the wound running in the medial lateral medial direction. I'm gonna go ahead and find the widest part of the wound, come up onto the edge, right where the wound ends and the edges are that you see the edges of the wound, and I'm gonna go ahead and take it all the way to the other side, and here I get 3.7 centimeters. So the next thing that we're gonna do is measure our depth of the wound, and to do this, we're gonna first go ahead and just start probing the wound with our cotton tip applicator. And so we're feeling springy end feel here, which indicates tissue, which is what we would expect for a wound with this presentation. Now to find the depth of the wound, I would go ahead and stop where I see the deepest part of the wound with my cotton tip applicator. From that position, I'm gonna go ahead and, keeping it perpendicular, run my fingers all the way down until I'm directly parallel and even with the skin surface and the edge. And I would go ahead and take that off, align my thumb with the beginning of my ruler, and measure my depth. So it's important when you measure the depth to make sure that you get eyesight so that you can see the highest part of that skin surface, where that skin surface begins to appear, and then you can go ahead and take your depth that way from the deepest part that you probe with the cotton tip applicator. The next thing we're gonna do is go ahead and look for tunneling. So to measure tunneling, we're gonna again kind of feel the wound, just kind of gently. We should feel a springy end feel here. And for tunneling, we're gonna note where we start to see a separation of tissue. So as we start to probe along the end of the wound, we'll notice that the actual tissue starts to separate. And we'll notice where this is directionally on the clock of the wound. So for example, if I saw tunneling here, this would be at like 9 o'clock. And I would only go as far to where I felt resistance. So it's really important that as we measure tunneling, we're not trying to cause additional trauma with the probing of our cotton tip applicator. So when we get resistance, we stop. I go ahead and align my thumb again with where that tunneling comes back, and I have access to where that skin first begins to separate, and I would measure my tunneling here. It's important as I do this that I would go ahead and find the tunnel at a specific direction, make sure that I find my probe and I go far enough to feel the resistance of where the tunneling ends. From there, I have my thumb there to mark the full length of the tunneling, and I can measure it again with my thumb on the beginning of my ruler and this way. Now, in order to do undermining, we're gonna go ahead and probe the wound again. And we're trying to make sure that when we do this, we keep the cotton tip applicator perpendicular to the skin surface. So it's really important to do this so that you can actually note where that undermining starts to occur. And what I'm gonna do is, if I find undermining for this wound specifically based off of the shadows, I would maybe just take a hunch that we would see some undermining anywhere between 3 o'clock to 9 o'clock. So if I were moving this and I started to feel the undermining of the tissue and my cotton tip applicator come underneath that wound edge, I would go ahead and probe all the way along, staying perpendicular until I felt that undermining stop. So if I saw some undermining, I could say if it ended from say 3 to 9, that might be where my undermining may be for this wound. From there, I have to go through again, and I need to find the deepest part of the undermining. So say if my deepest part of the undermining was here at 6 o'clock, I'd go ahead and similar idea with our tunneling. I'd go ahead and allow myself to find resistance to where it stops, but not pushing or trying to cause over resistance on the wound already, but just until I feel that resistance, I'd go ahead and mark when I see that skin surface with my thumb, okay, where that undermining stops, and I'd go ahead and again measure that on my ruler. So when we are looking at this wound, we would say that this is a full thickness wound. This is a full thickness wound that we would classify as erythematous epithelial tissue. So as noted by the picture, being able to kind of give our best explanation, we don't see any red beefiness, but I see based off of the picture, erythematous epithelial tissue. I would say that this tissue of the wound bed itself is 100% viable, and it's red and pinkish in appearance. As far as the pear wound, I notice a smaller dark circle that first you can kind of see mostly from 2 o'clock all the way to almost about 8 o'clock. And that darker circle around the wound is also surrounded by maybe close to about 1 centimeter of slough, more noted on the inferior segment of this wound. And this would be indicative of hyperkeratosis or callus formation that we see around the wound. And we can also note, kind of just looking at this again as a picture, this could possibly be related to the glare, but I do notice maceration occurring and that white shiny appearance from around 8 o'clock up to 9 o'clock, and then it definitely is a little bit less apparent, but you still kind of see some of the pinkish. So this I would not say is necessarily maceration, but as far as this medial inferior part right here, some maceration could be noted based off of what we see on the picture of this wound for the pear wound. We would say that these wound edges are unattached. You can notice the shadows of appearance that are indicative of those wound edges actually detaching from the wound bed itself. Now my etiology for this wound, I would say, is peripheral neuropathy. Based off of the HPI, the patient was unable to feel the 5.07 monofilament on 5 of the 9 locations. And this would mean, and the interpretation of this is loss of protective light sensation. There's no indication in the HPI in the patient's history of pain, and the wound was noticed due to drainage, which does also help me to better infer that this is a diabetic, possibly pressure ulcer wound, but diabetes as the upstream cause. The ABI was elevated, which is indicative of hyperglycemia, stiff peripheral arteries as suspected in patients with diabetes, and the elevated ABI rules out arterial insufficiency. The wound location itself is on the medial plantar aspect of the foot over the first metatarsal, and that is actually an area of high stress that would be anticipated as well with these diabetic patients. Lastly, we can see that the wound edges are unattached and calloused, which based off of what we know about diabetic wounds themselves, this is what we would expect to see with a diabetic patient. So my interpretation that the etiology of this wound is from diabetes, possibly a pressure ulcer, that the patient did not notice until they noticed the drainage coming from their feet. And from at this point on, I'm going to go ahead and throw my ruler and Copeland tip applicator away. I can go ahead and get the dressing and reapply the dressing here. And then I'll go ahead and doff, hand sanitize, make sure I throw everything away in my clean field to complete my wound measurement and assessment today.